Opioids are an integral part of severe pain management in hospitalized patients. What specific opioid should we use? Should it be oral or IV? This is the topic of today's video. In this video, we'll cover the following opioids: morphine, hydromorphone, fentanyl, remifentanil, oxycodone, hydrocodone, and tramadol. I will not discuss meperidine and codeine, as I highly recommend against using them for reasons I will mention soon. Let's start. Before starting opioids, remember the following, please. First, non-opioids should be tried first, as I discussed this in my previous video. I highly encourage you to watch that video. A link to the video is provided below. Second, is it safe to initiate opioids in our patients or not? All opioids can cause respiratory depressions, so please delay using opioids on those with decreased level of consciousness or respiratory rate less than 10. Also, some opioids, particularly morphine and hydromorphone, induce histamine release, causing itching, hypotension, and bronchospasm. Hypotension particularly can be profound with some opioids. It's better to delay administering opioids until blood pressure is more stable. Bradycardia is a side effect of most opioids. Use extreme cautions in patients with heart rate less than 50 and avoid it if possible with heart rate less than 40. Use extra precautions when using opioids in elderly patients, morbidly obese patients, and patients with obstructive sleep apnea and obesity hypoventilation syndrome. Telemetry and continuous pulse oximetry are paramount in these patients, although I highly recommend that all patients using opioids should have this kind of monitoring. Let's move on and talk about the specific opioid agents. Again, I will not be discussing meperidine and codeine. Meperidine is associated with significant neurotoxicity, and I don't see why should we use it anymore. Codeine has low potency and should not be used for analgesia. You still can use it for some cases of severe dry cough. Remember, we are talking about inpatient settings in this video, not outpatients. Let's start with fentanyl and remifentanil. They are very potent analgesics. Each 1 mg of fentanyl or remifentanil is equivalent roughly to 100 mg of IV morphine. That's why they are dosed in microgram mcg, not milligrams. They are not associated with histamine release, which means less hypotensive effect, making them appropriate for patients with hemodynamic instability. They are safe in advanced hepatic and renal impairment. They have a quick onset followed by a quick offset, with an onset of action within 3 minutes and a duration of action of 30 to 60 minutes for fentanyl and 5 to 10 minutes for remifentanil. The ultra-short action of remifentanil makes it only appropriate for continuous infusion only. Fentanyl, on the other hand, is preferably used as a continuous infusion, but can be given as an on-as-needed basis every 30 to 60 minutes. Please do not order fentanyl PRN every 4 to 6 hours. The starting dose for fentanyl is 1 to 2 mcg per kg, which typically range roughly between 25 to 100 mcg. For remifentanil, I recommend you look the dose up, as it's given as a drip with or without a loading dose. All these characteristics of fentanyl and remifentanil make them ideal for critically ill patients. Remifentanil can be very helpful when frequent neuro checks are required, given its ultra-short effect. Its effects wears off in minutes. One word about the fentanyl patch here. Fentanyl patch should be used in chronic pain only, not acute pain management, similar to extended release opioids. We are only discussing acute pain analgesia today. Let's move to hydromorphone. It comes in oral and IV preparation. Please avoid IM administration. More potent than morphine. Each 1 mg of IV hydromorphone is equivalent to 7 mg of IV morphine, while 1 mg of oral hydromorphone is equivalent to 4 mg of oral morphine. It can be given every 2, 4, or 6 hours as needed, or as a part of patient control analgesia, PCA. Hydromorphone is safe in advanced renal impairment and advanced hepatic impairment, although dose adjustment may be required in advanced renal impairment. It is associated with histamine release, leading to itching, hypotension, and possibly bronchospasm. The starting dose is 0.5 to 2 mg. I typically start at 0.5 mg for IV hydromorphone. These hydromorphone characteristics makes it appropriate for patients who are hemodynamically stable. Let's move to morphine. Morphine comes in IV, IM, sub-Q, and oral forms. It's given every 2 to 4 to 6 hours as needed, or as a continuous infusion as part of patient control analgesia. It is safe to use in hepatic impairment. Please avoid in advanced renal impairment. Similar to hydromorphone, it's associated with histamine release leading to itching, hypotension, and possibly bronchospasm. And the starting dose usually 2 to 4 mg. How about oxycodone? Oxycodone comes in oral forms only. It is instant release form, comes as a single entity of 5 and 10 mg or combined with acetaminophen as 5/325 mg or 10/325 mg given every 4 to 6 hours as needed. It is safe to use in advanced and hepatic renal impairment. How about hydrocodone? Hydrocodone comes in oral form only, similar to oxycodone. The instant release form does not come in single entity only. It comes combined with acetaminophen as 5/325 mg or 10/325 mg given every 4 to 6 hours as needed. It is safe in hepatic impairment, but please avoid it in advanced renal impairment similar to morphine. How about tramadol? Similar to codeine and meperidine, I don't see any reason why we're still using tramadol. And the reason for that, it has a very variable analgesic effect based on the speed of tramadol getting metabolized by the CYPD2P enzyme in the liver. Based on that, patient can be slow metabolizer or rapid metabolizer, and the effect of tramadol greatly varies in between them. Add to that tramadol serotonin effects, which may lead to seizures or serotonin syndrome. That's why I highly recommend against using tramadol anymore. So to sum this up, fentanyl and remifentanil are the most potent opioids, followed by hydromorphone, followed by morphine. Fentanyl and remifentanil are appropriate for hemodynamically unstable patients, making them appropriate for ICU patients. All opioids are safe in advanced hepatic impairments. Hydrocodone and morphine are better avoided in advanced renal impairment. Hydrocodone and oxycodone come in oral forms only, while fentanyl and remifentanil come in IV and no oral forms. Morphine and hydromorphone are associated with histamine release leading to itching, hypotension, and bronchospasm. Please avoid giving antihistamines preemptively. If the patient is complaining of itching, non-sedative oral antihistamine should be tried first. If IV sedative antihistamine is needed, space them out from the time IV morphine or IV hydromorphone were given and make sure the patient is closely monitored. Now, based on all of this, the patient's condition should guide us on what opioid should we use. In critically ill patients, we said fentanyl and remifentanil are the ones to go for. They are not appropriate for floor patients given their short duration of action and continuous monitoring needed. In hemodynamically stable patients, pick oral over IV if feasible. We can use hydrocodone/acetaminophen or oxycodone or oxycodone/acetaminophen. If oral opioids are inadequate, then we can use IV morphine or hydromorphone. I typically start with IV morphine unless the patient has advanced renal impairment where hydromorphone is safer to use, or if the patient is requiring high doses of morphine, which means more fluid volume to be given, switching to hydromorphone can reduce the amount of fluid volume. Or if the patient insists to have hydromorphone instead of morphine, I don't mind it at all, but I do the math for the conversion we mentioned earlier. A patient who is getting 4 mg of IV morphine every 4 hours as needed can be transitioned into hydromorphone 0.5 mg every 4 hours as needed. Remember that IV opioids, particularly IV morphine, should not be used in acute coronary syndrome unless the chest pain is refractory to nitroglycerin or there is a contraindication to use nitroglycerin. Please wean patients of IV opioids as soon as possible with transition into oral opioids or non-opioids medications. If unable to wean off IV opioids, use the strategy I mentioned in my previous video, link is below. But in brief, we do the following: add schedule acetaminophen or NSAIDs, add schedule gabapentin, and add schedule oral opioids if inadequate response to 1 and 2, and escalate the gabapentin dose. In the end, if you would like to receive a PDF summary of this video and future videos, make sure to sign up with the link provided in the description field. If you have signed up already, the summary should be in your inbox 24 hours after the video is released. If you find this video useful and worth a like, please hit the like button now, share it with your colleagues. Thanks for watching and see you soon.